A healthy outside starts from the inside. If your inside is beautiful, you will be having beauty outside. But it all depends upon the mass, the things which are inside. So that is the matter. Now, coming to the diagnosis of hyperthyroidism, there are five parameters. Number one, medical history and physical examination. Number two, blood test. Number three, imaging. Number four, ultrasonography. And number five is the fine needle aspiration. First, medical history and physical examination. During physical examination, one should note the classical signs and symptoms like weight loss, enlarged thyroid gland, the goiter in front of the neck, rapid or irregular pulse, and the palpitation, slight tremor in the fingers and the hands when extended, fully overactive reflexes of the body, heat intolerance, warm, moist skin, and sweating is there. Eye changes like ophthalmos means bulging eyes outside. And here one can see the parameters responsible for diagnosing the hyperthyroidism. That is a physical examination. One can use the hormones and the antibody blood test to measure the thyroxine, and then thyroid ultrasound to see any enlargement or the adenoma, and fine needle aspiration biopsy to see the nature of the tissue of the thyroid gland, whether it is cancerous or non-cancerous. Then radioactive iodine uptake to see how much the iodine the gland is taking, whether high or low, and then CT or MRI scan can also help as the part of imaging. Now, number two parameter is the blood test. For those who do not have classical symptom, as it confirms the diagnosis by the blood test. Typically, there is low thyroid stimulating hormone, TSH, and ideally the raised T3 and T4 is seen. Thyroid stimulating hormone, as one knows, produced by the pituitary gland, which is in turn regulated by the hypothalamus TSH releasing hormone, that is TRH. A low TSH level means pituitary gland is inhibited or instructed by the hypothalamus by sensing that there are increased level of the T4 or T3 in the blood. So that stop via the negative feedback mechanism. Rarely, low TSH indicates primary failure of the pituitary or another illness that is called euthyroid 6 syndrome. So one should always check T3 and T4. Now, here one can see the mechanism. The hypothalamus going to release TRH and affecting the pituitary gland, and pituitary gland in return from the TRH effect just release the TSH. This TSH is going to affect the thyroid gland directly to produce T3, T4, and calcitonin from the parathyroid gland. Now, if there is excess of these hormones, T3, T4, there is negative feedback mechanism, and that causes the negative feedback inhibition to the pituitary gland to just stop releasing the TSH, and also to the hypothalamus to just control the release of TRH. Now, continuing the blood test, false thyroid blood tests are seen if one do take the biotin. So, measure the specific antibodies like anti-TSH receptor antibodies in the Graves' disease or anti-thyroid peroxidase in the Hashimoto's thyroiditis. The third parameter of diagnosis is imaging radioactive iodine uptake or radioiodine uptake and thyroid scan. Here, radioactive iodine, traditionally iodine 131 and preferably iodine 123 is used. It is injected or taken orally as the form of pill or liquid on an empty stomach, and one have to measure the amount of the radioactive iodine absorbed by the thyroid gland just after 24 hours or 1 day later. Persons with the hyperthyroidism absorb more radioactive iodine, and that is easily measured. And here one can see the person has taken the radioactive iodine that is ingested in the form of liquid or anything, and here is the gamma probe or gamma camera which measure the thyroid gland radioactivity. Thyroid gland do absorb the radioactive iodine, and that is being measured by the gamma camera. Same here, one can measure via this probe and also by this scan. The aim is to measure and here one can do the thyroid scan under this machine. Now, normal range of the thyroid uptake is 10 to 30%. A thyroid scan produce images to allow the visual examination of overfunctioning gland, and thyroid scintigraphy involves two tests, an iodine uptake test and a gamma camera scan, so that one can reach to diagnosis very amicably. Sometimes the patient is allergic to iodine or the contrast media, so we have to use the antihistamine as a prophylaxis. Some test for the T3, free T3, T4 and or free T4 for the more detailed results are measured, and in hyperthyroidism CKMB, that is creatine kinase, is usually elevated. Now, the fourth parameter in diagnosis is thyroid ultrasound. High frequency sound waves to make images of the thyroid can find thyroid nodules. Even no exposure to the radiation, so useful for the pregnant and breastfeeding ladies and those who are radioiodine sensitive people. If no symptom there and the patient is not pregnant, there is no need for going off screening like this. The fifth parameter is fine needle aspiration, that is to see condition of the thyroid gland tissue, whether it is going in which way, hypo, hyper or cancerous. Subclinical in overt or obvious primary hyperthyroidism, TSH levels are low and T4 and T3 levels are high. But in subclinical hyperthyroidism, low or undetectable serum TSH level, but there are normal free thyroxine level. So that is the difference. Here, treatment of the elderly person can reduce the atrial fibrillation and bone fracture by 42%. So here one can see how the thyroid ultrasound is done, and this is how that under the guidance of the ultrasound probe one can go for the nodule or other thyroid gland tissue to have the tissue by fine needle aspiration through a syringe and needle length. It is called FNAC. The beautiful imagination of a person who have created it, really remarkable and praiseable. Now, coming to the treatment of hyperthyroidism, treatment depends on age, physical condition, cause, severity of the disease, and the personal preference of the patient. Three main treatment modalities or options are there: antithyroid drugs, radioiodine therapy and surgery. First, the antithyroid drugs. The drugs which are used are called thyrostatics. Static mean to stop anything. They can stop the production of thyroxine. So thyrostatic drugs that inhibit the production of the thyroid hormones are carbimazole, methimazole, and propylthiouracil. They inhibit iodination of thyroglobulin by the thyroperoxidase enzyme, which are responsible for formation of tetraiodothyronine, that is T4 formation is dependent on this process. Now, propylthiouracil works outside the thyroid gland and it prevents the conversion of inactive T4 to active T3, which is actually responsible for causing the effect of thyroxine. Thyrostatics take weeks to become effective as thyroid glands a lot reserve the thyroid hormone, so one have to give a very high dose early in the treatment and titration of the dose is difficult, so sometimes a block and replace attitude is used. Here, thyrostatics are given in very high dose to completely block the thyroid hormones and the person goes into hypothyroidism, which can be corrected by giving the thyroxine later on. Antithyroid medicine treatment lasts for 12 to 18 months and it rarely causes the liver damage. So these are the drugs which are used as antithyroid medicine, that is carbimazole 5 milligram, methimazole and propylthiouracil tablet 50 milligram, propranolol, these are the beta blockers which are given to treat the symptom, and spotev, that is 20 milligram, 40 milligram, 80 milligram, and metoprolol tetrate, that is also the beta blocker, that is the spotev treatment. Now, antithyroid drugs, beta blockers that block the beta receptors on the cell surface, so control symptom of the palpitation, trembling, anxiety and high blood pressure. For immediate temporary relief, these are given until the disease is treated by the other ways to stop causing all these symptoms. Some effect on the thyroid hormone production seen with propranolol, which has two roles. L-propranolol causes beta blockade, so treat the symptom, but the D-propranolol inhibit the thyroxine deiodinase and ultimately so block the conversion of the T4 to T3, which is the active thyroxine. Other beta blockers used are metoprolol, and one have to avoid these beta blockers in asthmatic people, and other side effects are fatigue and sexual problem if being used for a longer time. Now, classification of antithyroid drugs for convenience are inhibitor of the hormone synthesis. These are the carbimazole, methimazole, and propylthiouracil. Inhibitor of the hormone release, that is the iodides of sodium and potassium, and organic iodides. Then radioactive iodine 131 is being used, and the ionic inhibitors are thiocyanate, perchlorates, and the nitrates are sometimes used as ionic inhibitor. And radioiodine therapy, number 2, is in treatment. This treatment causes gland to shrink. It involves taking iodine 131 by the mouth as pill or liquid one time, which is concentrated in thyroid gland and destroys the hyperactive thyroid gland. It is called radioisotope therapy. It was first pioneered by Dr. Saul Hertz. The radioactive iodine 131 is preferred as treatment over the radioiodine 123, which is preferred in scanning. Iodine 131 emits beta particles far more damaging to the tissue, and that has a half-life of 8 days. So, continuous damaging effect on the thyroid tissue. Treatment can be repeated if first dose failed. Since iodine is picked up mostly by the overactive thyroid cells, destruction is local and there is no side effect seen. Here is the Dr. Saul Hertz, and that has done a lot in the nuclear medicine. Now, how the radioactive iodine works. Radioactive particles are attached to the iodine, and this radioactive iodine enters the thyroid cells, and thyroid cells, that when it takes the radioactive iodine, that cell glows with the radioactive, and ultimately the cell dies. So that is the mechanism by which the radiation and the radioactive iodine is going to damage the thyroid tissue. The radioiodine therapy is contraindicated in pregnancy and breastfeeding, as the breast tissue also pick up some of the iodine. It is also not given in graves of ophthalmopathy, as it worsens the thyroid eye tissue. In these cases, do 6-week course of prednisone. No much risk of the thyroid cancer with this treatment there, and it has got higher success rate, which vary from 75 to 100%. Sometimes initially symptom worsens as the thyroid hormone is released into the blood due to the destruction of the thyroid cells by the radioactive iodine. These cells contain thyroid hormone, so that released into the blood to worsen the symptom initially. So use the beta blocker, propranolol, atenolol, and other for this kind of crisis. Neck tenderness or a sore throat may occur as the side effect of radioiodine therapy. The third option of the treatment is surgery, thyroidectomy, partial or the total. It is not used mostly, as the disease can be effectively treated by the radioactive iodine method. But one has to remove the thyroid if that is very large or it has cancer. There is risk of removing the parathyroid gland, which are embedded in the substance of the thyroid gland, and cutting the recurrent nerve during this surgery is also a complication. That causes problem of hoarseness of voice and the swallowing difficulties. Surgery is option who cannot tolerate or allergic to the medicine or that refuse the radioiodine taking. If toxic nodule, one can do removal or give injection of the alcohol inside the nodule to destroy the nodule. Thyroidectomy is the option for the pregnant people also. And if parathyroid glands are removed, maintain the normal blood calcium level later on. So here one can see the lobe of the thyroid has been removed, so that is called thyroid lobectomy. Here the subtotal thyroid gland have been removed, so it is called subtotal thyroidectomy. And here the whole of the thyroid have been removed, so that is called total thyroidectomy. The treatment of the thyroid eye disease: use artificial tears, drops, and lubricating eye gels. Avoid wind and bright lights. For severe cases, use corticosteroids. These lessen the swelling behind the eyeballs, and if not tolerable by the patient, alternates are teprotumumab, tocilizumab, rituximab, and mycophenolate mofetil used as alternate. Surgery like orbital decompression surgery is sometimes used. Here, bone between the eye sockets and the sinuses is removed to give more room and to improve vision of the eyes. In eye muscle surgery, scar tissue make the eye muscle short and disturb the alignment, causing the double vision. eye muscle correction surgery can correct this double vision. And here one can see the different alternate, that is Teprotumumab, and here it is Tocilizumab and Rituximab and mycophenolate mofetil. And the prevention of the disease, check iodine in the diet, as kelp, dulse and seaweed contain a lot of iodine, so check its use. Cough syrup and multivitamin contain iodine. If graves of thermopathy or dermopathy, avoid smoking. Keep eyes lubricated by the eye drops or the gel to relieve dryness and scratchiness. And if eyes do not close, tape the eyelid shut. Avoid the cornea from drying out, and use sunglasses to protect eyes from sun and wind. Use hydrocortisone cream to relieve red swollen skin on the shin and feet. So that is the end of the lecture of hyperthyroidism, and I have given as much as possible complete description of this topic, and hope you will like it. And if you like it, please subscribe and share with the others. If you have any question or query, please do not hesitate to talk to me. And last, thank you very much for watching.